All right, starting on page 299, we start talking about sex hormones. As we stated earlier, the anterior pituitary produces most of the hormones that influence the gonads. In males, the main androgen or male sex hormone is testosterone, and there are some other androgens that play a smaller role. Females, we have our two primary hormones involved in both secondary sex characteristics and childbearing and menstruation. So estrogen is the main female hormone, and then progesterone kind of helps control what goes on with the uterus. Menstruation has a lot to do with establishing pregnancy. Female sex hormones, like we said, the main ones are estrogen and then a category called progestins. When the female reaches the age of menarche or first menstrual period, the brain begins to release something called GnRH, or gonadotropin releasing hormone, and that begins to work. That comes from the hypothalamus, and then that stimulates FSH and LH to be released from the anterior pituitary. Now, two medications that can be given to replace estrogen that you are lacking or progesterone. The prototype estrogen is known as Premarin. That's a trade name. But they're basically all known generically as conjugated estrogens. One progestin that can be used for a variety of menstrual irregularities and other conditions is a drug called Provera. On page 302, we have table 16.3 that gives examples of these medications. And on pages 300 and 301, you can sort of read those over and look at different tables that talk about the negative feedback loop when you are talking about menstruation and ovulation. Estrogen begins to decrease in the period of time called menopause. There's perimenopause that can happen for years before your periods finally stop, where estrogen just starts to wane a little bit, and then finally you're not producing very much at all. With menopause, FSH is going to increase to try to stimulate more estrogen, but you're really not going to produce as much as you did. So we use estrogens to replace natural estrogens in menopause to kind of keep the health benefits of estrogen. And then other conditions like premature ovarian failure. And that happens in about 5% of the female population, where instead of going into menopause at about the age of 51, give or take a year, they go into it earlier, sometimes even in their 20s and 30s. Most of the time there's no real rhyme or reason behind that. But you can replace the estrogens that are lacking in that situation. Infertility workups will sometimes use estrogens as part of the testing and treatment. And then sometimes estrogen is used in treatments for breast cancer when other drugs have not been effective. On page 302, we see adverse reactions to estrogens and reduced estrogen levels, what that does, and then symptoms that you see in menopause because of those increasing FSH levels as the body is trying really hard to make you make more estrogen. So it's got the things like the hot flashes and night sweats that people experience when they're going through menopause. Progestins many times are used primarily for contraception. They also can be used to control overgrowth of tissue and pain in endometriosis. If someone is having excessive uterine bleeding due to problems with their periods, many times progesterones can take care of that. You can try to treat secondary amenorrhea. That occurs when the person has started their periods normally as scheduled, but then later on, due to hormonal imbalances, they start or will stop having menstrual periods. And then dysmenorrhea and premenstrual emotional effects can sometimes be helped with progesterone. So that kind of brings us to oral contraceptives, which provide one of the main reasons for women to take hormone replacement is for contraception. So most of the time you're going to have a combination of estrogens and progesterones, but there is a progesterone only contraceptive which isn't as powerful, isn't as effective, but will cut down on the effect of, or the different side effects. So these drugs are discussed on page 303, some of these combination drugs, and their action is to prevent ovulation. On page 304, the main risk of oral contraceptives is an increased risk of blood clots. It heightens the clotting factors in the liver, and so you're slightly more likely to get blood clots, possibly fatal blood clots, in the lungs if you're taking high estrogen oral contraceptives, especially if you smoke. So women over 35 who smoke and still are taking oral contraceptives are really highly advised to stop. Oral contraceptives can lead to excess of estrogen, excess of progesterone, excess of androgens. They can cause any of those imbalances, and so many times they just have to be adjusted. Make sure you read Patient and Family Teaching on page 304 when it comes to the contraceptives of all types. Plan B is basically just high-dose oral contraceptive, and it's been shown to prevent pregnancy within 72 hours of unprotected sex. It has to be within that 72-hour period or it's not going to be effective, but it's just basically like taking an extra high dose of oral contraceptives.